I'm going to take you back in this episode to the mid-1980s. Remember, these were the days where on the fashion runways, you'd see big shoulder pads, big hair. On the radio, Madonna, Michael Jackson. On the job, one young general practitioner and anesthetist. His first posting, Inuvik. Yes, Inuvik, north of the Arctic Circle. Well, that brand new GP was Dr. James Stempien. He went from Inuvik to Iqaluit, then to Papua New Guinea, to Alice Springs in central Australia. Well, eventually he found his way to Saskatoon, and today Dr. James Stempien still works shifts in emergency and oversees all emergency medicine in Saskatchewan. James Stempien's a board member with the Canadian Association of Emergency Physicians, and he's our guest today on Researchers Under the Scope. Hello, I'm your host, Jen Cannell, and we are recording this at Royal University Hospital. It's Tuesday, it's the 8th of April. Today, we are talking emergency medicine, what's changed over the years, what patients need most, and why texts are often the best place these days to send discharge instructions. And why even today, Dr. James Stempien says he has not, in fact, seen it all. The emergency department is still full of surprises. James, thank you for inviting me here to Royal University Hospital, and welcome to Researchers Under the Scope.
Thanks, Jen. Thanks for meeting me here.
Looking way back, Inuvik, take us back in time. What was going on in your life that made you say, yes, that sounds like a promising future?
I'd done a couple of years of post-medical school training. I'd done a rotating internship and a year of anesthesia, and I always sort of romantically looked at the Yukon and the Northwest Territories as a place to be, as a place to live. And I thought it'd be fascinating north of the Arctic Circle, and it was. It was great.
What happened when you arrived? Like, what kind of cases were you dealing with?
It was well before the time of computers. We were quite isolated. We had one flight out a day. I was a GP anesthetist, which meant I only had 1 year of anesthesia training, but we still had lots of really scary cases. Epiglottitis in a young kid that had to be intubated, which is a very difficult airway scenario, stabbings, shootings, and just regular cases. So it was always very challenging, but in the north there, we had quite a small physician community, but really a team sort of idea where our older physician, or the surgeon, was from France originally and had been in the French-Algerian Civil War. Docs who had just graduated, an interesting case came in, and you could call anyone at 2 a.m. and everyone would come in to help. It was a very sort of community team-based, almost like a medical rugby team. It was really cool.
And how long did you stay?
I was there a year and a half, and then switched over to Iqaluit after that. But that first year and a half, we serviced many communities all around the Mackenzie River. I used to go to Fort Good Hope once a month as their regular physician for that year and a half. I drove up to Tuktoyaktuk on the ice road. Yeah, lots of interesting things, lots of interesting cases, and a lot of really good people. And you felt you're doing a real service because, we were supposed to have a certain amount of physicians. We were always working a little bit short, but always having something interesting every day.
It sounds like real teamwork.
Yeah, it was. It was great teamwork, and if you didn't know something, it was easy to ask anybody to come and help you out, and therefore when anyone asked you to come on in quickly and help them out, you just ran in because it was that kind of community. Yeah, it's great.
And from there you moved to Iqaluit, then there was Papua New Guinea, there was Western Australia, and at some point, like, where did your passport take you?
Well, yes, good list. I worked in Iqaluit for a while, which is where I met my wife. I was there off and on for a couple of years as well. We went to Papua New Guinea, and I worked there for a year in an isolated community in the highlands called Yalabu, where we had our first child.
Whoa. Like, how isolated? Did they have generators or electricity?
Yeah, we had a generator, but we didn't have a phone, which made it a little more difficult. We had to go to the post office or the police station to make a call. We eventually got that fixed. We didn't have a working toilet in the hospital, and so our big achievement was to dig the new pit toilet, which allowed us to open up all the wards, which had been closed for a couple of years. And again, we traveled around that area because I was the only physician for a period of time in that zone, so we would have to do visits to other surrounding communities. And eventually we had a second physician who came from the Solomon Islands, so we were able to do minor operations because one of us would do anesthesia and one would do the surgery. Yeah, great place to work, interesting people, and, met someone who said he remembered what human flesh tasted like, so that was kind of cool because, it was part of the culture that they, part of the Papua New Guinean culture at the time. There was,
In what context did you have to ask him about his dietary habits?
I think it just came up because he was an older man and we were talking about a slow virus disease called kuru, which you find in the highlands of Papua New Guinea. And it usually affects the women because the women would eat the brain. While
like
the men,
ceremony.
Right, whereas the men would get muscles and heart. And they didn't eat a lot of people. It's just that, there'd be a battle, and the battle, as it was described to me, and that some of these battles happened when we were there. There'd be almost a showpiece battle where people would be going back and forth, and spears would be thrown, and maybe one or two people would die, and then the other side that won would, in ceremony, take that body and eat it as a victory type of ceremony. So it was in that context because we were talking about that.
It's still shades of chronic wasting disease and mad cow.
Yeah, no, it's very similar. That's what a slow virus is. Yeah, so very similar to that. I talked to one Papua New Guinean medical student about the set piece battles, and he said every now and then when he was home for the summer, he would have to dress up in war garb, and he would be in the battles. And I said, but you're a medical student. And he goes, yeah, I'm not very good either, so they keep me on the sidelines. So there you go. And I had a couple times where people came in after the battle, and I had to learn how to take arrowheads out of people's bodies and
I
stuff
was
like that.
wondering, because spears flying, that sounds like, keep a doctor handy.
Right. So not a lot of people would be injured, but some would. And so people came in with arrowheads embedded in them that they couldn't get out themselves, so we would have to take them out.
Have you ever had to remove an arrow since?
Surprisingly, no. In Saskatoon, it doesn't really come up very much.
That's for the best. Yeah. But at some point, when did your family say, okay, we'd like you to maybe settle down, Dad?
Well, I mean, it was just my wife and I and our newborn baby in Papua New Guinea, so all that was fine. But yes, I think my parents pointed out that I should settle down. Yeah.
And did you listen?
No.
Where'd you go?
Well, after Papua New Guinea, I think we came back to Iqaluit, and then we went to Central Australia. I was a Royal Flying Doctor in Alice Springs, and that was, again, another great job. Similar to Canada in terms of the isolation and their Indigenous population that probably doesn't have all the medical or infrastructure support that you can acquire in an Australian city, similar to the differences in Canada, right? So, again, it was an interesting job, and we felt we were doing good work because they needed physicians to do that type of work. And so, and got to fly around Central Australia and see lots of cool stuff.
Yeah. So at what point in your life were things happening where you said, Saskatoon, it would definitely be a good idea to move there?
After working as a GP anesthetist in these isolated areas for quite a while, my wife was going to do some more schooling, so we moved down to Victoria. And I realized that at that time I needed to have an extra skill if I wanted to survive in a bigger Canadian city. So I got my emergency medicine certification, the CCFPEM, through the College of Canadian Physicians, worked in Charlottetown for a while, worked in Whitehorse for a while, and we were actually in Abu Dhabi working in the emergency department in the Sheikh Khalifa Hospital, which was the main emergency for Abu Dhabi. So it was the emergency department that treated all the locals, the Emiratis. So there's a higher class hospital, but it was also the main trauma center. So it was very good work. It was very interesting work. But after a couple of years there, the being a department head in Saskatoon, came up and we saw the advertisement. And my wife's from La Ronge.
Oh.
So she's from northern Saskatchewan. So it just all seemed to gel.
And does she still get back to La Ronge now that you've been based here for a while?
Yeah. No, we still have our cabin in La Ronge. We were up there in February, and we go up in the summer regularly. And I don't know if you know La Ronge at all, but there's a Robertson's Trading in La Ronge, and that's my brother-in-law.
Oh.
That was my father-in-law. Yeah.
Oh, my goodness.
Yeah.
Okay, so deep enough roots, because that's the best part of 2 decades. You've been here at the University of Saskatchewan. And at a certain point, they said, hey, we'd like you to be a physician leader, not just attending to cases day in, day out. What made you say yes?
I think I've always had an interest in that sort of thing. I really enjoy medicine. I really enjoy emergency medicine. You make a difference with your patients, one patient at a time, and I think that's great. But, as a physician leader, trying to bring in positive changes, improvements in the healthcare system, you can make a difference to many people's lives with the right decision, with the right sort of infrastructure changes. It's kind of hard because a system like the SHA is a big system and there's lots of competing interests. But the emergency medicine is the front door of the healthcare system. And, they talk about the emergency being the canary in the coal mine. When things aren't going well, you see it in the emergency department, those sort of negative issues, negative problems, they're apparent in the emergency department first because we're the front door, we're always open, we're there 24 hours a day. And, many times if you need to see somebody at 3 a.m, the only place to go is the emergency department. And so we're there for everybody at all times.
Well, and the first time I really thought about emergency rooms and how busy they were is when they told us, hey, we can see COVID-19 coming. This is going to flatten our hospitals. Please, we've just got to slow this down. Everyone stay home for a bit. Just take it easy. COVID-19 went on and on and on. But what did it change inside the emergency department?
Well, during COVID itself, there's a lot of changes. When COVID was starting and we had the information coming from China and eventually the first sort of hospitals in New York, it was actually kind of scary because a lot of healthcare workers were dying because there was no vaccination. There wasn't adequate PPE supplies, which is, something that people were worried about. I think, to be honest, Saskatchewan did a quite a good, reasonable response. We saw things coming. We ramped up our PPEs. We still went to work in the emergency department, right? So, we
didn't
still
get to stay home.
Yeah, we didn't get to stay home. And that's good. That's what we were trained for, right? To be the people there for that type of frontline response. So I think we all understood that and we were all, rose to the job because we realized that's what we needed to do. But it was kind of difficult. You saw people, especially before vaccinations, who got very, very sick. Young people, healthy people. It wasn't just the old or the infirm. Young people who got sick, young people who went to the ICU, young people who died. And that was difficult to see. Once the vaccinations started widespread, obviously things were better and things calmed down. But it was unfortunate to see that, the only people we were seeing after a period of time who were still getting very, very sick were the people who were refusing vaccinations. And that was a difficult thing to see because you knew there was a potential answer to that. But it was a challenging time. But I think while there was a fair bit of stress for a lot of the frontline workers, I think we realized it was also part of our role to respond for the healthcare system, respond for the people of Saskatchewan, and do our best job. So I think it was something we were okay with, I guess, in some ways, right?
Well, we were so grateful for all the people in emergency and all the people dealing with all these COVID cases so that the rest of us could stay home and make our sourdough or whatever it was. But after, and so it feels like a before and after. COVID is still around, so it's not really after. But right. Now, what are you seeing in terms of people rolling into the emergency department? What's changed for them?
Well, it's, our acuity and our numbers in the emergency department haven't decreased since COVID. If anything, it's increased. We're seeing an increase in acuity in the emergency department, increase in numbers. And it's difficult to say exactly why, but again, that's multifactorial. The numbers of people who don't have family physicians in Saskatchewan and across the country is rising. And I think Saskatchewan, it might be as high as 18%. I don't know the exact number. But because of that, people aren't seeing their family physician on a regular basis. And we see people instead who, rather than getting regular healthcare checkups, finally come to the emergency department when things aren't going well.
Oh, when things are really rough.
When things are really rough. Saskatoon's increasing in population. They talk about the gray tsunami, people, as our population ages, we'll see more and more people who are coming into the emergency at an elder age. And, I'm 67, so it's going to be me sooner or later as well. And I think just maybe it's just harder to access family physicians or other alternative care. But, again, I worked in the emergency last night, and we were really busy, hours behind. All the ER docs there and the nurses were running our tails off, and we just never caught up. But everyone I saw, truly needed to be there. There were people who had an illness or a concern that needed to be addressed one way or the other that night.
So I'm hearing more people coming, more severe cases than necessarily before, when more people had access to family doctors.
Yep.
And how many have to be admitted and kept at the hospital?
If you look at the two major acute care hospitals in Saskatoon, St. Paul's and RUH, the average is around 20% if you combine those two, which is, depending on where you are across Canada, that's not that unusual a number.
And so how often do you get backed right up where you can't put people anywhere else?
Yeah, that's an issue, again, all across Canada, but certainly an issue that's really plagued Saskatoon for the last few years. It's an issue called bed block, where we have a certain amount of beds in Royal University Hospital, and they're meant for emergency patients. But once people are admitted, if they aren't able to be transferred upstairs to the ward, then they end up using up an emergency medicine bed. And we've had times where every emergency medicine bed in Royal University Hospital has been full of admitted patients, plus stretchers in the hallway full of admitted patients.
Waiting their turn to go upstairs.
All waiting their turn to go upstairs.
And nothing coming open.
And, very few coming open, right? The front door is open and people are piling in, and the back door is open, but almost nobody's leaving.
Oh, no. This is the worst nightclub ever.
Yeah, exactly. So it ends up being quite stressful, and we ended up seeing a lot of patients out of the waiting room because there was nowhere else to see them. We would call their name in the waiting room. We'd walk them to a stretcher. We'd examine them and walk them back to the waiting room, which, of course, since it ended up taking a little bit longer with each patient, ended up...
their chair might be gone.
Right.
Like somebody might be sitting there now.
Well, we did their best to get them their chair back. But just the same, we ended up, because of that lack of infrastructure and needing to go call your patient, walk them somewhere and walk them back, it was harder to keep the flow going because it took 5 to 10 minutes longer for each patient you saw, right? So that is continuing to be a difficult thing. We need more beds more acute care beds in Saskatoon. And to be honest, not too long ago, the government and the SHA announced they're going to be opening another 109 beds in Saskatoon City Hospital, which will take a period of months to open up that infrastructure and get everything set up. But that will certainly hopefully make a big difference in getting people out of the emergency room. We're doing other initiatives in terms of putting some of our admitted patients in the back hallway and trying to make sure we always have a few rooms to see our emergency medicine patients.
Leaving like a couple of those beds open.
Right, or even a few more than that, right, so that you have a place where emergency patients can be brought into. Because one of the issues is that once you're admitted, we know your diagnosis, we've started your treatment, but we don't understand what's going on with all that undifferentiated people who are waiting in the waiting room. There's sometimes 40 people in the waiting room, elderly, unwell, sick in various ways that we just don't know. So in that undifferentiated group, there's a lot of risk in not getting to them, which is why it's important for us to try different methods to open up emergency beds so we can continue to see our patients.
Well, yeah. And you must have to get through this many patients in an hour.
Yeah. There's theoretically, we try to get through 2 to 2.5 per hour, but it's, depending on how sick the patient is, and if you have to put a cast on, that takes time. If you have to sort of sew up somebody, that takes time. But yeah, I think all the docs do their best to keep running to keep that numbers going, because everyone realizes those patients in the waiting room are at risk. And so it's important to do our best to see as many as we can in a safe and efficient manner.
And you still make a point of working those shifts.
Oh, yeah. In fact, I like the shifts better than the meetings. You know, I mean, the meetings are important, but I mean, to be honest, the shifts remind me why I became a doctor, and I like the patients and I like talking to them, and you know, everyone's got a fascinating story, and so it's it's great working there.
All this time, you've stayed with emergency medicine too, and because you didn't go the anesthesiology route, you could have gone family medicine. There's so many different directions.
Yeah, when I started, because when you're working in these small communities in the north, you're a bit of everything, right? You know, so I would be doing family practice, I would be delivering babies, I would be doing anesthesia. So in those small hospitals, you're a jack of all trades, right? And which made that work really fascinating. But yeah, once I came down south for a period of time, I realized I needed that constant change or challenge, and so emergency medicine just seemed like the right fit.
And it still is.
Yeah.
Each day is
great.
still.
Each shift is great. I'm always learning new things. I'm always seeing things I'd never seen before. It's kind of funny. Right after 40 years, you think that
After the cannibals and arrow tips were moved. Really? Oh my gosh.
You see, I've gotten to the point where there's many things I've seen thousands of times, but every now and then you run across something and you think, wow, I've never seen that before, right? So, and that's what makes emergency medicine interesting and fun and bad. And, usually the emergency medicine team, the nurses, the physicians, and the other allied healthcare staff, they're all members of our team. We look out for each other. We support each other. We actually have, fun on the job because it's a constant changing environment. So yeah, it's great being there, not just for the medicine, but for the group of people that we work with.
I did want to ask you about. I've looked at. There are so many papers that you've contributed to, and so much published work you've done over your career. Recently, I understand you were part of a study where we looked at giving discharge instructions, but making sure the person could pick them up by text.
Yeah, that was. It was a study, and I worked with a couple other physicians, Dr. Puneet Kapoor and Brian Rennie, who were the computer guys because they know computers much better than me. But yeah, the whole point is that, when you're giving discharge instructions, studies have shown the best way to give a discharge instruction is to give the patient some sort of written document of some kind. And at one point years ago, we used to always have these flyers and we'd hand them out to the patients, but that sort of stopped during COVID because we weren't wanting to give out, papers and all that sort of stuff. We could theoretically type up something and print it out, but our computers aren't always attached to the printer. The printer's not always easily accessible. And at times people will just scribble something on a prescription pad and maybe you can read it, maybe you can't, right? So we developed a study that basically we have a series of well-vetted discharge instructions, things like for concussion, nosebleeds, there's a whole series of them. And you can get the patient's phone number on our app. The discharge instruction will be a text directly to their phone number. So I used it last night. I asked the patient his phone number. I texted a concussion instruction to him. It came on his phone. He was able to look at it, ask me a few questions about it, and now he's got it forever. The way it's set up, that because all this is through the cloud and encrypted, once I text it to him, I don't know his phone. It's not kept in any database, and he can't trace my phone even though it's coming from my phone. So it's all sort of privacy concerns are kept. There's a space where you can add your own instructions. So you can add up to 200 words of your own instructions to say that
very specific to this.
Specific to this patient. If you're not better in 3 days, please see your family doctor, or I've arranged an extra test for you just to remind you that it'll happen on this day. And so
how long have you been sending them out this way?
It was just last year that we ended up finishing this pilot study. We've gotten a grant to sort of expand our work, and we were at a EDAC conference last November, a conference in Toronto, Emergency Department Administrative Conference in Toronto, where a bunch of other people from different jurisdictions looked at our app and thought it was fantastic. And so it's actually being used in some hospitals in Toronto right now.
That's awesome.
Yeah, I think it's a good initiative for the patient to actually have the instructions on their phone. They can access it as many times as they want. They're not going to lose the piece of paper on the way to the parking lot.
You've seen the instructions floating.
Yeah, we've seen the instructions in the past, hanging around, and it allows them to have something they can access. And often on the instructions, like the concussions instructions, there's links to other resources they can access as well. So yeah, I think it's a good initiative, and I think anyone I know who's used it has felt as positive.
And you can go back in and see what they've done too. Like you can see if they've actually read it. You can see how many times they've looked back at it.
There is an ability to see if the patients have accessed the app more than once or looked at them more than once. So future studies will be to look at that sort of numbers about how often these are accessed, or are there some discharge instructions that were better than others?
What were the hits?
Yeah,
what were the misses?
Yeah, exactly. Yeah.
I love that. Well, it sounds like, again, and this is in a long list of research publications that's aimed at making things easier and smoother for both patient and physician. Because somewhere, if that person does come back, there's got to be a record of, hey, these were my instructions last time, right? Like, okay. In terms of the future for emergency medicine, I'm assuming if you don't stick around another 40 years, what do you see happening, especially for Saskatchewan, that's cool or that we could really follow up on?
Well, I think last year, emergency medicine across the country has had some problems because there are problems with bed block and flow issues are not just in Saskatchewan, are all across the country. The last year, the number of people applying to emergency medicine for training actually dropped.
Oh.
It was always one of the most popular residencies, and it's recently been dropping for the last year or two, I think because of all the negative things in the news.
Yeah, it does sound like it's just like a sea of monkeys, and what is going to happen if I go there? Do I really want to take this on?
No, it's true. And I think people wonder about that. But I think taking back our space, owning our space a little bit more, realizing that if we can improve our flow within the emergency department and get a better handle at seeing our patients with the resources we have, we can still give good care. I think any of the medical students or residents I know that have come through the emergency department for some training with us always end up thinking, that it's a great team atmosphere. It's a lot of great learning, and the whole concept of, seeing patients and helping them one-on-one when they're at their most vulnerable. Like patients don't come into the waiting room because they're having a good day, or into the emergency department because they're having a good day. They come to the emergency department because it maybe is one of the worst days of their lives, right? And here we are able to make a connection, make a positive input in their life, and hopefully make things better for them, or at least communicate as best we can to help these patients. I think it's a really unique job in terms of what we have. And not everybody really relishes the chaos in the emergency department, but people who do, I think really, really enjoy it and really realize what a positive impact they're having. So I think, if we can turn around that bed block issue, not just in Saskatchewan, but across the country, I think we'll see people sort of again embracing emergency medicine. I think they still do. It's just, I think as you noticed, some people have noticed it's a sea of monkeys. But
chaos. But it can also be beautiful. It's what it sounds.
Oh yeah, absolutely. There's not a shift where I don't think that I've made a positive impact on somebody's life, right? So
that's really cool.
Yeah,
wow. It is. Thank you so much, James.
Oh, you're welcome. It's great to be here. Thank you very much.
Dr. James Stempien came to the College of Medicine at the University of Saskatchewan back in 2007. Today, he serves as Saskatchewan's head of emergency medicine. He still works shifts at RUH in the province's busiest emergency department. He and his colleagues have spent years trying to make things there more efficient, more safe for both patients and for the human beings trying to work in emergency medicine. You'll see more on that text message discharge study that he was just talking about over the coming months. Watch for updates at medicine.usask.ca. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research at the University of Saskatchewan's College of Medicine. We record and produce this podcast on Treaty 6 territory. We pay our respects to the Métis and First Nations ancestors of these places, and we reaffirm our relationship with one another. This is where we'd like to thank you for listening in, for being a part of it. Who knew that travels to remote parts of the earth, cannibalism, and emergency medicine would all end up in the same episode? I am your host, Jen Cannell. Go ahead and share this episode with someone who you think would enjoy it. And thank you for sharing your ears with Researchers Under the Scope.